Just breathe. Yeah. Hello. Hello. Okay. Good. All right. Okay. All right. So now let's see what we have here. There we go. I see. Okay. Okay, good to go. All right, so Zoom. Oh, Macy, this is yours. Right. Okay. Very good. Okay. All right. Yes. Yeah. No, it's left. For Lynch, it's left.
Okay. When I looked it up, it said right side. I have the same thing. I have the same thing.
I think because all the papers I read said left.
No, I was just
The
wondering.
book says right?
I can check. When I looked it up at the Cleveland Clinic, said that it was right-sided is much more common.
That's interesting because the last big study of Lynch syndrome in 2016 says left. And then, what's that big guy called? Harris's said it's left. So,
Question 5 in the true or false question says Lynch syndrome will usually present with IDA as it affects the left side of the colon.
let me look at this. Hang on. Right, and it doesn't, if it's on the left side, it doesn't present as IDA. It presents as obstruction. It's on the left side. But the IDA is on the right side because it grows as an exophytic mass that gets damaged and bleeds. All right, so quizzing time. Oh dear, I should fix that, I guess. Which means I should give everyone credit for it since it's hard for myself. All right. Okay. I would like to share something with you before we start. I X'd it out, darn it. All right, well, anyway, there was a report, it was a news report I wanted to show it to you. There was a conference that was supposed to occur on the campus of the University of North Carolina. And the session was run by an outfit called Genetic Engineering and Society. It's a pretty well-known outfit that tends to weigh the risks of genetically modified organisms in society, in medicine and agriculture, things like that. And it was canceled because people who had nothing to do with the university, or rather people who had nothing to do with bringing the particular conference, complained that all the people on the panel were white. So whether or not someone has something to teach you is based on the color of their skin. How's that not racist? So I look at you based on the color of your skin. That determines whether or not you have something to teach me. To me, that's a textbook definition of racism. Maybe I'm not with it these days. But when I was growing up, if you prejudge someone based on the color of their skin, that was racism. Yet all of a sudden, it's okay. Will somebody please explain this to me? Because I'm not smart enough to understand this. No takers? Yeah, I don't get it either. I don't get it either. So I hope regardless of the color of someone's skin, you're able to learn from them. Very good. So we are going to finish osteogenesis imperfecta, and then we will get into muscular dystrophies. All right, quick review. So we looked at this case study of a kid with osteogenesis imperfecta. What are some of the things that a kid with osteogenesis imperfecta might have, say, at birth?
Their legs will be like properly.
Okay, legs might be in a funny position. Aaron, what else?
And broken bones.
Broken bones. Okay, blue sclera, the eye, blue sclera. Which is kind of sort of give away that one. There aren't many things to do that. So just the birth itself can cause bone breakage. Just normally caring for the child in the way you care for a kid can actually potentially cause fractures, completely unintentionally. And then, oh, good gravy, look at that. And the bones have funny collagen. Because they have funny collagen, the calcium hydroxyapatite salts that are deposited on them don't make good, strong interlaced crystals, and you have fragile bones. So we looked last time at the importance of collagen 1. We saw that mutations straight in collagen 1 tend to lead to more severe types of osteogenesis imperfecta. Mutations in other genes that are involved with the packaging, the folding. Collagen is an interesting protein. You have 3 polypeptide chains that are wound together in a triple helix. That's why it's very tough, very strong. Part of that ability to do that is due to the fact that proline, which is necessary to put a kink in the protein, that's why it's able to turn the way it does, proline is not going to hydrogen bond very well because it's a secondary amino acid. It's the only secondary amino acid. So in order to get proline, something to hydrogen bond with, this enzyme here hydroxylates proline. That is a proline hydroxylase. And one of the cofactors for that enzyme is ascorbic acid. Now, what do we call ascorbic acid in dietary terms? Come on, you nutrition people, you're in nutrition now. Ascorbic acid is which vitamin?
C.
C, right, vitamin C. Very good, vitamin C. That's why deficits of vitamin C, which cause scurvy, will cause things like teeth to get loose, joints to get very lax, your eyes don't sit in their socket as well as they should. It's potentially quite dangerous. All because essentially your connective tissues are not as strong as they should be because you're not hydroxylating that proline. And think essentially of this type of osteogenesis imperfecta as a really advanced case of scurvy, almost an inherited type of scurvy. So these types of proteins here will give you osteogenesis imperfecta, but it's not quite as severe as if you have a mutation in the structural gene for collagen 1 and 2. So genetic testing of the more severe types of osteogenesis imperfecta, fortunately, is pretty straightforward because the sequences of those genes are quite well understood, quite well known. Also, collagen is made as a big precursor and then it gets clipped until it eventually gets outside and then it's a lot shorter than it was when it was first made. So as it says here, some 90% of individuals with the various types of osteogenesis imperfecta have mutations in those particular genes. So these mutations, they code for amino acids found in the front of the protein, the N-terminus. They don't result in the modified collagen, but they interfere essentially with the folding of the final collagen. And that makes it hard to pick them up on a gel, essentially. So you're going to have some other ways to test for it, other than PCR technique. So with this defect, as it turns out, you can pick it up through biochemical testing. And what you do is you take a little punch biopsy of the skin, you grow the fibroblasts in culture, you then give them these, well, traditionally radiolabeled amino acids. Nowadays, you don't use radiolabeled amino acids, but you can still do that. And then you take the collagen that the skin fibroblasts will make, that's a major protein that makes collagen, and you run it on a gel. And the defective collagen will have an altered migration in a polyacrylamide gel. Now, I don't know if any of you have ever either seen or done these types of experiments, but you have a this gel. It's made of polyacrylamide, and polyacrylamide, when you initially put it together, depending on the concentration of it, you have a different percentage polyacrylamide gel. And polyacrylamide, depending on the percentage, makes a molecular pore that's of a different size. You're going to load your protein. So there's buffer essentially, like this. You take your protein and you load your protein with glycerol and some dye and stuff like that. And then you You then, this is a low salt buffer. You turn on the electricity. There's an electrode here and here. And the protein has been loaded with a detergent called sodium dodecyl sulfate. Think of it as a soap, if you will. Sodium dodecyl sulfate is negatively charged. It binds pretty tightly to the protein and denatures it. That makes the protein negatively charged, and it will migrate towards the positive pole. So the protein now is going to move through the gel, squeezing its way through that molecular pore system. And the bigger it is, the tougher time it's going to have squeezing through those pores. Smaller it is, the faster it's going to shoot through those pores. And your protein is going to give you a band on the gel. Now, we do this in my biochemistry class. We do bunches of these actually in our biochem class. And the bands are pretty easy to see. And if you use radioactive nucleotides, you can then use a counter that will detect radioactivity. And you can have control cells that you can buy from ATC Corporation. And if their collagen, say, is of a different size, that tells you you have a collagen that migrates at a different rate. It's a mutant collagen relative to this one. So this is your control. And this is your, say, patient. And you notice that they don't line up. And I usually have still standards on this side so you can gauge the size of the protein and what have you. These, you can buy these. Lots of places buy them. In fact, they buy them now so they're labeled with dyes. Each protein has a different dye. They're called kaleidoscopic markers. So you get this rainbow color like that. You get red, blue, yellow, green. It's really cool. That's handy because you can just look at the gel without staining it and know where things are before you stain it, which is very cool. So this type of experiment is not terribly hard to do. I could take you upstairs and show you how to do it. You know how to do it. It's not that hard. And this will detect 98% of your cases of classified osteogenesis imperfecta, at least type 2, and about 90% of osteogenesis imperfecta type 1. 98%, 90%, that's not too shabby, is it? No. So this type of testing is done. You need a biopsy for it. And you can use this to detect abnormal collagen. Since collagen is the thing that's abnormal, and collagen, there's lots of it, so it makes a good band on a gel. This is pretty reliable. And then you can also screen them using PCR, polymerase chain reaction. Polymerase chain reaction can cover essentially the whole coding part of the collagen gene. That will usually pick up variants. There are plenty of variants in this gene that don't cause any disease. But there are variants that do. And if you pick those up, then you have a variant of high certainty. Because ultrasound is so good now, ultrasound can tell you if you have bones that structurally are abnormal. Ultrasound can also tell you about bone density in the fetus. And a good ultrasound technician, good radiologist, can essentially look at those bones and say, they don't look right. Prenatal testing is available as well. So you can do this through chorionic villus sampling or amniocentesis. Amniocentesis isn't just for doing karyotypes. You can actually use it to isolate DNA and then to run PCR tests on that DNA as well. That's a possibility. And if one of the more lethal forms of osteogenesis imperfecta is about 20 weeks gestation, you'll usually be able to detect it on an ultrasound. Milder forms you can't detect terribly well using ultrasound prenatally, only the more severe ones.
But the more severe ones, do they usually die?
Yeah, they usually die, and it's usually because the ribs collapse and the baby dies from respiratory failure.
Does that happen more in utero, or does it happen more
It
often?
can happen both. Which one is more, happens more often? Oh boy. That's going to depend essentially on what kind of prenatal care, whether it gets how active she is. If the kid is, being bounced around, which experience usually, the experience of pregnancy usually is that when you're walking or moving around, that tends to rock the baby, and the baby tends to not move very much. The baby's kind of chilling. When you sit down though, when you're resting, when you actually want some time to yourself, then the little fart starts, really letting you have it, because you stop rocking the thing to sleep, and then it stands on your bladder and does that, and yeah, great. I think you're gonna be a teenager someday. That sort of movement, because now remember, the baby is moving a lot before you ever feel it. There's some remarkable fiber optic pictures done by that Norwegian guy. What was his name? He passed away. He was doing the Amazon forest. He was on a line, and then the line broke and fell hundreds of feet to his death. But he did some of these really remarkable fiber optic pictures showing essentially that even very early, as early as 5-6 weeks, the embryo will actually start to kind of do this flapping thing. So the baby is moving long before quickening. You have that feeling of pregnancy. So can that movement essentially cause bones to break in the severe type? Yeah, it can. And some kids move more than others. And that's just the way it is.
So say you see this on your ultrasound, is it more, do they just go and have like a C-section so that they're not going through the
Usually, yeah. And then there is a protocol. Not all hospitals have them. They may send you to a hospital for a high-risk pregnancy. In cases like that, to try and help the little guy, be able to not have their chest collapse, and there's special respirators that can be used and stuff like that. Usually, even despite your best efforts, the kid's going to expire usually, and so it's more comfort care at that point, and just helping the parents to spend some time with the little one before it dies. I mean, that's the part that sucks about the job you're going to do, is that people are not going to get better, they're going to die. And as much as you wish that wouldn't happen, that's part of life. That is the end of life. And so you have to kind of, in your head, be ready for it. And I think there's a class you do as a senior that talks about that, because you just have to be ready for it. And it's going to stink, but that's the way it goes. So yeah, there are protocols, but even the best protocols, a kid that is really, really severely sick is not going to survive usually. So there is no treatment for osteogenesis imperfecta, and to manage the disease, as you see here, you have several specialties all working together. Orthopedics, of course, physical therapy, of course, pediatric dentistry. There are types of things you can paint on teeth to make them stronger when it comes to the dentinogenesis imperfecta. Otology and otolaryngology, because of the tendency to lose hearing. And because some of the cartilage may be affected too with swallowing, or even phonation, forming words might be an issue as well. So for those who have the dentinogenesis imperfecta, the dental care is meant to take that permanent dentition and make it last. Implants might be an issue, but you're implanting into bone that doesn't work very well, so implants can't be used all the time. For fractures, usually you're going to use rods that will help provide a scaffolding through which the bone can get reestablished. Casting, of course, will be very important. Make sure the bone heals straight. If the bone is not well set, then the bone will heal funny. And bones that heal funny are going to be more common in this particular group. And then braces. Braces are very important, particularly to support the spine. If the spine is not properly supported, you don't have good posture, the spine is going to deform. So bracing is quite important as well. And as the spine deteriorates, so will the intervertebral discs. So to summarize, an osteogenesis perfecta is a result of abnormal collagen, abnormal bone-dependent collagen, albeit type 1 collagen is also found in joints as well. That leads to poor bone density, bone instability, abnormal bone growth and healing, and what have you. There's 8 recognized types, but we really only know the genes for 6 of them. And the majority of those with it inherit this as an autosomal dominant. And some are the result of sporadic mutations, not ones they inherit. Most of the people who have the more mild cases essentially may be able to live with, they'll have several fractures, fragile bones, a few fractures, but the blue sclera and the short stature is a big giveaway. Progressive hearing loss and the dentition issues, those are a giveaway too. There's no real treatment, but there are protocols for helping people live better, and those require a multidisciplinary approach. Any questions about osteogenesis imperfecta? I can't say you will see people with this, maybe you will. It's not hugely common, but you might, depending on what you practice. Ooh. Now we're going to talk about muscular dystrophies. All right. I'm sorry, guys. What's so funny? You guys have been laughing ever since class started. It's Friday. Okay, fair enough. Fair enough. Or you could just do what Emily does, stuff. All right, let's start with a little case study. 32-year-old Mary comes in with her 6-year-old son. Let's call him Thomas. Mary notices that Thomas is often clumsy, weak, and has trouble climbing the stairs at their house. Mary is worried because she had a brother who presented the same symptoms as a child and developed progressive weakness until he passed away 23 years of age due to respiratory problems. On physical examination, Thomas has scoliosis and very thick calves. Scoliosis and very thick calves. Later that day, we have 29-year-old Sarah. She comes to the clinic with her 10-year-old son, Mike, because Mike has progressive muscle weakness and fatigue, as well as vomiting and lack of appetite. She also mentions, in addition, he tends to have seizures. So what do these two little chaps have in common? Both have muscle weakness. they both have a condition essentially characterized by weakness and progressive weakness. It's been getting worse. So when we talk about muscular dystrophies, we're talking really about an array of different conditions. Some of these are going to show very distinct type of pathologies and different inheritance schemes. So our 6-year-old Thomas and our 10-year-old Mike, both of those little guys have some sort of inherited disease characterized by progressive muscle weakness, muscle wasting, and muscle atrophy. So these are caused by mutations that affect the production of muscle proteins. And these muscle proteins help not only muscle function, but also help maintain healthy function. Now we will talk about muscular dystrophy. There's different types of muscular dystrophy, and depending, on the type of mutation you have in this dystrophin gene, that will determine whether you have the very severe Duchenne muscular dystrophy, or whether you have the not quite as severe Becker muscular dystrophy. Now, dystrophin is an X-linked gene. Since it's X-linked, who's going to tend to show the condition? Males. Males. So the two most common of this group are the Duchenne and the Becker. There are, however, other types of muscle dystrophies, muscular dystrophies, that result from mutations in mitochondrial DNA. Now, if you have mutations in mitochondrial DNA, those mutations will tend to be passed through the mother only. Because during fertilization, the egg is a whole lot bigger than the sperm. So the egg really has most of the mitochondria that will get passed to the progeny. Sperm, quite small, and when the sperm fuses with the egg, a lot of the mitochondria in the sperm get dumped. It was thought that all of them got dumped. Now it turns out that most of them get dumped. There are a few that still last. So one shows an X-linked type of, so sex linkage, sex-linked inheritance. The other shows a maternal mode of inheritance. It's supposed to be an age. There. So both Duchenne and Becker muscular dystrophy result from mutations in the dystrophin gene. Dystrophin gene is X-linked. All males with the mutation will develop the disease. Females will have one functional copy and one not functional copy. Females, therefore, will tend to not show the condition. Now, females, however, do show this phenomenon called X inactivation. This is the so-called lion hypothesis. What is the lion hypothesis? So, since males have one X chromosome, and females have two X chromosomes, the way the female body deals with this is it takes one of those X chromosomes and turns it off. It inactivates one of them. This occurs very early in development, and the decision as to which X chromosome gets shut off is random. Random. So, is it possible for a female's body, if she's heterozygous, for mutations in dystrophin, to have some weakness in certain muscles? Yes, it is. It is. This is a phenomenon called mosaicism. And therefore, women who are heterozygous for mutations in the dystrophin gene can show some weakness in particular muscles of their body. If those muscles are descended from cells that have the copy of the X chromosome with the wild type version of the gene inactivated. Good way to illustrate this is with there is a certain type of genetic disease, again, that's X-linked, and it prevents you from making proper sweat glands. Males who have this condition tend to die rather young because without sweat glands, you have trouble thermoregulating. Women with this condition, though, will only have patches of their body without sweat glands. And they can survive, therefore, but they still have patches without sweat glands. All right, so that's the lion hypothesis. It's named after a British geneticist who took white blood cells from the blood of females and discovered that one of the X chromosomes was visible in the light microscope, and it was called a bar body. A bar body. And the bar body is that inactivated X chromosome. And again, this happens very early in development and random. So those cells that will then go on to make your body, some of them have copy A inactivated, others have copy B. So men with muscular dystrophy cannot give it to their sons because they give their sons their Y chromosome. And every daughter born to a mother who's a carrier has a 50% chance of becoming a carrier. What is the dystrophin protein? The dystrophin protein attaches the contractile elements of the muscle to the plasma membrane. So without it, the muscle will contract, but it won't change size. People with Duchenne muscular dystrophy have a nonsense mutation that results in a very short dystrophin protein that's not functional. Whereas people with Becker muscular dystrophy make a full-length dystrophin, but it's not a normal dystrophin. That's why people with Becker muscular dystrophy will show symptoms later in life than people with Duchenne muscular dystrophy. People with Duchenne muscular dystrophy tend to show symptoms by age 5. People with Becker muscular dystrophy will tend to show symptoms between the ages of 10 and 20. pause, questions? So initially, the muscles, even though they are degenerating, excuse me, degenerating, will regenerate to try to keep up with muscle degeneration. Problem is, muscle regeneration can't keep up with muscle degeneration. And so the muscle will atrophy and start to become infiltrated with fat and scar tissue. This process can occur in any muscle, but the muscle that shows it most noticeably is the calf muscle. This is called pseudo hypertrophy of the calf. Pseudo hypertrophy of the calf. Now, because of the weakness that occurs in the pelvic girdle, as you step, when you swing the leg, the hip has to come up. Because the muscular dystrophy prevents this from being able to swing up, the walk now, essentially, in order to get this up, they're going to have to swing over like this, and then they'll have to swing back. So you get this waddling gait, where you're swinging back and forth to move the hip up in order to swing the leg, essentially. So that's called a waddling or myopathic gait. A waddling or myopathic gait. It's very characteristic. As the muscles around the hips and the upper legs start to weaken, it becomes very difficult to stand. And so kids will show something called a Gower's sign. So a Gower's sign, very simply, is if the kid is on their stomach, how would a kid normally get up this way? Right, they do something like that. Muscular dystrophy kids can't do that. Here's how they get up. That's a Gower sign. Because their legs aren't strong enough to do that, so they walk themselves up like that with their arms. And no, I won't demonstrate that again.
How are their arms strong enough to do that?
They're small enough as to where their center of gravity is towards their head. So because they're moving their head, they're able to get upright essentially by pushing their head. And some of them might even put their head on the rug and kind of brace themselves at the head and stuff like that. So eventually the arms won't be strong enough to do that. It'll usually be, so they start showing symptoms at 5 where they get weakness. And with the case study, remember he couldn't climb the stairs. So the Gower sign essentially would appear soon thereafter, instead of getting up and, because when a kid learns to walk, all of a sudden they're running around everywhere and terrorizing you. But usually these folks, once they get to the point where they don't, it's too painful to stand, so they sit around all the time. And if they need to get up, they don't get up a normal way. They walk themselves up with their arms. That's your Gower sign. Sydney?
This is just really interesting to me because I lifeguarded this summer and I noticed a kid that had like really large calves and like it was so weird. And he got it cool funny too. He would like most kids like crawl up out of the side, but he would like lay on it and then try to like awkwardly put his legs up on the side.
Oh,
Yeah, I don't know.
that, yeah. Oh. Okay. Yeah, great.
My question is, like, with the balance. So my niece gets up normal, so like we put her in the little baby Carhartt overalls. She tries to get up like that because she can't bend her knees. And every time she falls right forward. Would it be typical for them to lose their balance since they can't really like?
It's more a strength issue. It's less a balance issue. They can't brace themselves well enough to be able to show it. And with the waddling gait too, the other thing that does is it tends to deform the spine. So scoliosis is also very common in these kids as well. So she's strong enough to stand up. It's just balance. She tips essentially.
Well, only in her overall. So thick.
How old is she?
She's 15 months.
She's probably fine. So usually by the age of 13, kids with Duchenne muscular dystrophy will need a wheelchair. They won't be able to walk on their own. It's not uncommon for them to be paralyzed from the neck down by the time they're 21. And with Becker muscular dystrophy, this will be delayed by at least 10 years usually. A weak diaphragm eventually will cause respiratory failure, and then this extends also to heart muscle as well. So you have dilated cardiomyopathy and arrhythmias. And most people with Duchenne muscular dystrophy will die in their 20s. Most people with Becker muscular dystrophy will die usually in their 40s. Walking on the toes is also something you see in kids. They're trying to keep their weight forward because they don't have enough strength so they will tend to try to, do stuff like this. And difficulty sitting up, standing up, you have the Gower sign. And then there might be some motor learning disabilities because of that as well. So the pseudo hypertrophy occurs in the calf. And the replacement of the muscle tissue with the scar tissue and the fat, that can make the calf muscle, the gastrocnemius, seem a lot larger than it is. Now, because of the scar tissue, the muscles, when you feel them, they might seem very stiff. You might think they're degenerating, that's going to cause them to be kind of flopsy. No, the scar tissue can make them seem very stiff. That's something else that you should see. Now, kids usually, when you feel their muscular tissue, it's squishy. That's why it's easy to tickle kids, because they're kind of squishy all over. And they're so ticklish. But usually when you feel the same tissue in a kid with muscular dystrophy, it's hard, it's stiff, it's like a board. All right, so the later signs and symptoms, we have an inability to walk, limited movement on their own. I always get this question, so let me just predict it. Does physical therapy and physical activity delay this? It does. Doesn't put it off indefinitely, but it will help. Because of a weak diaphragm, they'll have breathing problems usually. You'll see, again, because of the scar tissue, it's shortening muscles and tendons and things like that. The spine has a funny curvature. Scoliosis is most common, but kyphosis can be seen as well. Later on in life, dilated cardiomyopathy is pretty common. That may start to cause arrhythmias. They may also start to have chest pain. And then difficulty swallowing, because the muscles for swallowing, they are affected. That can cause aspiration pneumonia. So in cases like that, you'll have to get a speech therapist consult, since they're the ones who do the swallow tests, to ascertain which food will be best for the patient. When my wife did special ed at Warner, before ISD shut down the special ed program, there was a kid in that class with Duchenne muscular dystrophy. And they would put him on the carpet so he could sit up, and they would kind of try and get him to do that, to just force him to do that. He was in a motorized wheelchair. But I was there, I did a little science show for them, and they said, well, can you pick him up and put him on the carpet? I said, sure. And dude was dead weight, just dead weight. He was, how old was he? Oh, 10 or 11, I think, or something like that. Yeah, I thought you said that kids get in wheelchairs by 13. Well, he was early because his mother spoiled him and never made him do anything. So. The Gower sign, very evident. When you see a Gower sign, it's really hard to miss. And it's a classic sign when the child has weakness in the proximal muscles of the hips, the hip flexors, so the child will walk up to the legs using the hands. You're going to see that early. Natalie's question about not having enough strength in the arms to do this, eventually the strength will be lost. So this is a pretty early sign. Lab tests show that you have elevated creatine kinase. Normally, creatine kinase is something that is released when you damage muscle. So if Bree goes out on the soccer field and runs back and forth many times, she'll probably have a high creatine kinase after a game where she's running the length of the pitch. You know, you're a bully, right? But say she ran the length of the pitch multiple times, she would have probably elevated creatine kinase. These levels that you have in the case of people with muscular dystrophy are quite high, abnormally high, beyond what you get, say, from somebody weightlifting or working out or something like that. You'll also see myoglobin, which myoglobin levels, small amounts of myoglobin are not that big a deal. So that indicates breakdown essentially of muscular tissue. A biopsy of muscle is usually not necessary. But if the genetic tests and the laboratory tests are inconclusive, that's your last resort, because the muscle in a biopsy shows a very characteristic structure. And if you remember the slides of muscle you looked at last year, skeletal muscle is a really regular appearance about it. It's like a marching band, kind of all lined up and with the nice striations and so on and so forth. Muscular dystrophy muscle is going to be all over the place. There's also a there's a particular stain you can do. It's called the Gamori trichome test. The Gamori trichome test, if you stain the muscle with this Gamori trichome stain, it will show you essentially signs of the muscle breaking down really very distinctively. So that's used for the biopsy. Now, the genetic tests are available for muscular dystrophy are quite good. They detect lots of the mutations. The downside is that the dystrophin gene is huge. So you're going to have a mutation practically anywhere in the darn gene. And trying to find it can be looking for the proverbial needle in the DNA sequence haystack. There are certain areas of the gene that where certain mutations cluster, though. You can just test those areas. That's why genetic testing tends to be pretty good, even though the gene is really, really big. So as we said, the Duchenne muscular dystrophy is the most severe. Becker would be the next most severe. And then there's something called a myotonic muscular dystrophy, sometimes called Steiner's disease. This one tends to affect the face and neck muscles. It's weird that it really only affects those muscles of the face and neck, and it tends to only come on during your adult years, usually middle adult years. So that would be essentially one of the most mild forms of muscular dystrophy. Then there's a congenital type, and it's not due to a mutation in dystrophin. This congenital version is not terribly frequent, but it's evident very early, affects both males and females, and its progression really is all over the place. In some people, it progresses very quickly, and others, it doesn't. Other types of muscular dystrophy include so-called Emery-Dreifuss. Emery-Dreifuss. That is characterized by joint contractures. Joint contractures and then wasting. Contractures are usually not seen in other types of muscular dystrophy. Fascioscapulohumeral is restricted to the pectoral girdle, and you have a condition where you have certain weakness of the ability of the body to keep the scapula in its proper location. So you get this condition called scapular winging, where the scapulae essentially start to do this. So this scapula, that's why it's called winging, because it's a little bit like wings, and that's due to the infraspinaceus and the supraspinaceus not being able to keep the scapula in place. So this comes on during the teenage years. Usually, it says onset can be almost any age, that's true, but it's usually the teenage years. And it affects the face and the shoulders, not the lower body. Limb girdle, this can be early or later. It can just be a issue with dorsiflexion, and they may have trouble with balance and things like that. People with limb girdle can live even later in life. Doesn't seem to affect the heart. So dorsiflexion, if you ask them to stand on their heels or something like that, to walk on their heels like that, I can't do that. You're supposed to be able to do that, and you're supposed to be able to pass your foot underneath it.
What? Stand up?
So turn around, it's glass. Okay, you're gonna stand on your heels, and I'm gonna try to put my toes under. Ready? Stand on your heels, okay? Yeah, see, I can put my foot under there nicely. Yeah, don't fall. See, just completely normal. Now do it and be wimpy. Yeah, be wimpy. No, not wimpy enough. Okay, now up, see, up, yeah, see, now. So if someone essentially you can't put your foot essentially under there, your toe, that's essentially what you're looking for with this. And then the so-called oculopharyngeal muscular dystrophy. This tends to come on in middle age, even older age. And it affects the eyelid, throat, and face. The disease may progress down and affect the shoulder. It may even affect the pelvis later on. But people don't tend to die from this. It's relatively mild as muscular dystrophy goes. So you have your Duchenne, your Becker, but there are other types of muscular dystrophy as well. Okay, and that's all for today. We will talk about the genetic testing. We'll also get into the mitochondrial DNA diseases. And then on to chapter 16 after this.
Thank you.